Our participants are on mute, so if you want to chat a question in the chat box, feel free to do so. Just remember, you may be sending this to everyone if you don't choose the Echo Tobacco name itself, but it's fine if you want to send everyone a chat and ask a question. That's how we'll be doing Q&A at the end. So we are going to get started very quickly. I'm going to let Claudia Rodas, who's going to close us up, describe more about our coalition, but we are made up of a group of over 50 organizations that are supporting Texas' effort to raise the tobacco age to 21 years old in the state of Texas. But this webinar is the second webinar held in a series of outreach events to educate on health disparities and how it's related to tobacco within our state, and how this policy can specifically shape the behavior of youth and young adults to eventually change the landscape of what our state could look like in the years to come if we were to raise the age. I'm going to do quick introductions of our speaker lineup. We have Tia Olarinde from the Department of State Health Services. We have Dr. Lorna McNeil from MD Anderson Cancer Center, Dr. Lorraine Reitzel from the University of Houston, Dr. Colleen Bridger from the San Antonio Metro Health District, and Claudia Rodas from the Campaign for Tobacco-Free Kids. So at this point in time, Tia, I will send it over to you to get us started. And ladies as speakers, feel free to do some brief introductions on your own if you like, just trying to save time and just kick us right off. So Tia, let's get started.
Thank you, Jennifer. Hello, everyone. Today I'm here to provide information as it pertains to who smokes in Texas and the populations most susceptible to smoking-related illnesses. Next slide, please. To start, I'm going to highlight smoking disparity rates in Texas by socioeconomic status, sexual orientation, and other health issues, as well as discuss rates of tobacco-related diseases. So to reference the smoking rates by SES, the parameters that I chose to use include educational attainment, health insurance status, and income. To begin, I just wanted to start by giving the smoking rate in Texas for 2017. Among all adults in Texas, the rate was 15.7%. Among those without a high school diploma, the rate of smoking was 21.1%. And among those who were college graduates in 2017, the smoking rate was 5.4%. Next, among those without health insurance in Texas in 2017, 24.1% of people were without health insurance were smokers, compared to 13.1% of people with health insurance in Texas that smoked. Also, among those who earned less than $25,000 in Texas in 2017, the smoking rate was 19%. Versus the smoking rate of 10.8% among those who made above $50,000 in 2017. So as we can see, there are substantial disparities in smoking rates by SES, and the reason for these disparities encompass all aspects of the social determinants of health, including, like we mentioned, lack of education, lack of access to health insurance, poverty, and the environment, which includes the probability of a person seeing tobacco ads and also seeing certain types of tobacco being sold in their own neighborhood. Among race and ethnicity in 2017, the smoking rates were as follows. The rate was 16.5 for whites, it was 17.0 for African Americans, and it was 15.3 for Hispanics. And among various sexual orientation in 2016, the smoking rate for Texans who indicated on the Texas Behavioral Risk Factor Surveillance Survey that they were indicated to be LGBTQ, the smoking rate was 19.5, and among those who indicated they were heterosexual, the smoking rate was 14.3. And for other health issues that have smoking disparities, I've included some information about those who indicated that they suffered from depression and had a disability status. So in 2016, those who indicated they suffered with depression, the smoking rate was 21.8. In those without depression, the smoking rate was 13.2. Among those who had indicated they had a disability status, 21.4% was the smoking rate, and among those without a disability status, the smoking rate was 13.8%. So as we can see from these different various data that I just displayed here, there are definite smoking disparities among different populations in Texas and nationally as well. Lastly, I just wanted to highlight a national study and give some national statistics on smoking rates among people who live in HUD housing. So in 2017, there was a study that showed between the year 2006 and 2012, the smoking rate was 33.6 among people who live in HUD housing. And the Texas rate for this was unavailable. The passing of the HUD Public Housing Smoke-Free Rule, which stated that all public housing authorities had to go smoke-free by July 2018, only restricted people from smoking in the unit and 25 feet from a building, but it did not restrict a smoker from living in public housing. So of course, there's still people who live in public housing that are smokers. Thank you for changing the slide. My last slide depicts the incident rate of tobacco-related cancers by race and ethnicity in 2015. There is a disparity among African Americans and whites, even though if you can remember the smoking rate among the two were not much different. So in 2017, it was 16.5 for whites and 17.0 for African Americans. These disparities can also be attributed to the similar social determinants of health that I mentioned earlier, and are pervasive among other health outcomes not shown here. Thank you.
Thanks, Tia. We're going to transition now to Lorna McNeil, who's going to do a deeper dive into health disparities related to cancer, and this is her area of research here at MD Anderson. So Lorna, we're going to make sure you come off mute and you have permission to advance your slides.
Okay, thank you so much, Jennifer, and happy to be participating in this webinar. I think that some of the information that Tia and I provide will overlap a little bit, but like Jennifer said, hopefully some different information, and look forward to future questions and answers. Hold on. Okay. So I wanted to just start with the definition of health disparity, so we're all using the term, I guess, interchangeably and in the same consistent way. And very often we'll use the National Cancer Institute's definition of health disparities, which focuses on adverse differences in cancer incidence, prevalence, mortality, survivorship, and burden of cancer or related conditions among specific population groups in the United States. Very often when we think about disparities, we really focus on race, ethnicity, and that makes sense because it's easier to understand and see disparities when we look at them in big aggregate groups. But it's important to note that we aren't just concerned about race and racial and ethnic differences in these particular outcomes, but there are other subgroup populations in the United States that experience these type of disparities, and we want to understand the causes of those disparities and how to address those as well. So those groups also include those defined by disability, gender, sexual identity, geographic location, social economic status, which includes income and education, and many other characteristics. And in the subsequent slides that I present, you'll see the various ways that I will break up disparities based on these subgroup populations. One of the basic tenets of disparities, though, why we care about them, is because there's something about these disparities that are happening to these subgroup populations that's disproportionate. It's disproportionate to their numbers in the population, or the prevalence and or incidence or mortality that exists, that is unnecessary and avoidable, meaning that there might be potential solutions out there that can ameliorate these disparities, and so therefore we need to put our collective efforts towards figuring out how to address this through these populations. And then there's also a notion that it's just unfair and unjust, that there is no real reasonable explanation for why this is occurring, except for our sheer lack of will and lack of desire to want to ameliorate those disparities. Ultimately, we want everyone to have similar outcomes across the board, that it doesn't depend on your race, ethnicity, disability status, where you live, and the level of income and education you have, but that to the extent that we want to eradicate cancer until that day happens, that we all have similar incidence, prevalence, mortality rates, and quality of life that we experience. And so this is the lens with which I'm going to be talking about disparities today. This slide shows the number of new cancer cases each year, and it's displaying it here by race, ethnicity, and sex. And so just as a refresher to note that men are more likely to get cancer in terms of new cancer cases than women. But then among the racial and ethnic groups, Black men are significantly more likely to get cancer compared to all of racial ethnic groups, and that white women are more likely to get cancer among all racial ethnic groups. And you can see the rest of the distribution there. When we want to know who dies from cancer each year, and again, this is across the United States, you see the same pattern that men are more likely to die. And similarly, among males, Black males are more likely to die among all racial ethnic groups. But here you see a slight difference where Black women are more likely to die of cancer, even though they're less likely to get cancer in the United States. These data are from Texas specifically. And as you can see in terms of who gets cancer in the state of Texas, and this was between 2011 and 2015, slightly overlapping with my previous slide, that you see similar rates here among non-Hispanic whites and non-Hispanic Blacks, with significantly less cancer incidence rates among racial and ethnic groups. So not quite the disparity that you might see nationally. But again, when you look at who dies from cancer in the state of Texas, you see a similar pattern emerging where non-Hispanic Blacks are still more likely to die of cancer in the state of Texas as well. It's also important to note that where you live does matter. And so these are one of these understandings of disparities based on geographic location. So this slide is looking at cancer death rates by race, ethnicity, by sex, which I've just presented, but also by state. So what I've selectively done is, I'm sorry, I have to move all of you over so I could see the rest of the slides. Hopefully I'm not covering it up. But this purple represents rates among Black males in the US. This is Texas. This is Harris County. And I'm here in the city of Houston, which is in Harris County. And then this is New York. And what you'll see is that really for white males, Black women, and white women, it really kind of doesn't matter where you live, either be the US average in Texas, Harris County, and New York, that you have similar chances of dying from cancer regardless. But for Black males, it actually does matter where you live, whereas Black males that live in New York actually look like white males across the rest of the country, whereas they have a significantly higher death rate if you happen to live in the state of Texas. So again, these are one of these understandings where you want to figure out what is it about where you live that might be causing these type of disparities that exist, and are there programs and policies that can help mitigate that. So when we look at disparities, sorry, I'm trying to forward the slide. Sorry. There are some other disparities that occur by other various cancers. So it's likely well known that African American women are twice as likely to be diagnosed with triple-negative breast cancer than white women, are much more likely to die from that cancer. It's a much more aggressive cancer. American Indians, Alaska Natives are more likely to die of kidney cancer. For liver cancer, there are higher rates among American Indian, Alaska Natives, as well as Asian and Pacific Islanders. In the state of Texas, there are much higher rates for liver cancer among Hispanics as well. It's very well known about prostate cancer disparities with African American men. For rural areas, cervical cancer is higher among women in rural areas than those who live in urban areas. and African Americans are more likely to be diagnosed with multiple myeloma. So again, not just race, ethnicity, but wanting to understand other factors that might be in play here. When we want to understand what causes those disparities, we can look at genetic and biological factors at the bottom. And so some of these cancers might actually have biological determinants, such, for example, the research on triple-negative breast cancer suggests that. Healthcare access is really critical and really important, that if you get cancer, the disparities with which you get cancer, we are still trying to understand, but the death rates may in fact be due to getting access to care. For example, we know that being treated at an NCI designated cancer centers, they do confer better health outcomes than when you're treated someplace else. But there's only about 50 NCI designated cancer centers in the country. So not everybody can be seen at one of these cancer centers, for example. So healthcare access does matter. I'll go into socioeconomic status a little bit more in subsequent slides, but physical exposures, and then diet and physical activity, of course, preventable factors that are associated with disparities, and these factors are more common in racial ethnic minorities and other disparate groups. This slide is looking at lung cancer incidence by race ethnicity. Again, this is in the state of Texas. And I'm going to focus on lung cancer, of course, because we know that tobacco is a causal factor as it relates to lung cancer. And so here you can see that Blacks are slightly more likely than whites to have lung cancer compared to other racial and ethnic groups, but very similar comparable rates for lung cancer among whites and Blacks in the state of Texas. So who is smoking across the U.S. and in the state of Texas? Here we see a map and can see in terms of disparities by geography that who is more likely to smoke is highly concentrated in the South and in the Midwest in the United States, which is these darker colors here. So it ranges from Utah, that has the lowest rates of about 8%, to over 25% in some of these more southern areas. I think West Virginia might have, or Kentucky has the highest rate. Somebody may be able to correct me. And Texas is somewhere, in the middle, not too shabby, not too, bad, but obviously because of the relationship with lung cancer and multiple other cancers, we definitely want to address smoking rates. So about 38 million of Americans still smoke, even though those numbers are coming down. And right now in 2016, the average was about 15% of U.S. adults. And in terms of who's more likely to smoke, it's men, adults 25 to 64 years old, lower education, below the poverty level. I mentioned Midwest and the South. Those that are uninsured or on Medicaid, disabled, have serious psychological distress. American Indian and Alaskan Natives is actually more like an epidemic in terms of smoking in those populations, as well as with lesbians, gays, and bisexuals. This slide here over the right is showing who smokes in the state of Texas. And so right now in 2016, about 14% of Texas smoke, so we're below the national average. But you can see here, men are more likely to smoke. You can see these very high rates of American Indian, Alaska Natives in the state of Texas, almost double that of whites. And then you can look at the breakdown by age as well as education, and it mirrors that we see in the U.S. average as well. When we are talking about disparities in terms of who smokes, there is diversity that exists among racial ethnic groups. So the Hispanic is not just one monolithic group, as we all know, as well as Asian and Pacific Islanders, that our tobacco rates may differ depend on country of origin. So this next slide, if I can shift it, looks at disparities in adult smoking within racial and ethnic groups. So if we take, Asians that might smoke at lower rates, but when you look at Koreans, their smoking rates are much higher, and we look at Vietnamese as well. And as a matter of fact, Vietnamese men have the highest smoking rate, and for sure compared to Vietnamese women. And this slide over here is also looking at Hispanic ethnicity, but it's looking at Mexican, Puerto Rican, Central South American, and Cuban. And again, you can see very stark differences in terms of the Hispanic group, where a lot of smoking lies is in the Puerto Rican population. If we had similar data for African Americans, and you could break it down by folks that are Caribbean, folks that are from African countries, U.S.-born Blacks, you likely see these same disparities. So it's important to understand that in each of these racial ethnic groups, a ton of diversity exists, and to the extent that those data are available, we want to understand those nuances in terms of who we really should be targeting in terms of where the smoking lies. Just some more data on disparities in tobacco use. And Jennifer, if I'm running over, you can stick your finger up and let me know. Okay, I gotta quit. But this is, I mentioned, higher smoking rates among LGBTQ populations compared to heterosexual populations. And I don't know if you guys can see the bottom of these slides, but I see you rearranged it. And then this is looking at cigarettes and cigars and smokeless tobacco by poverty status. And again, you see those that are lower income are more likely to smoke. Some other factors that African-American children and adults are more likely to be exposed to secondhand smoke. I mentioned that people in rural areas are more likely to smoke and have higher lung cancer rates than those in urban areas. And interestingly, people of lower socioeconomic status are just as likely to attempt to quit smoking, but are less likely to be successful than those who have greater means. Again, wanting to give a sort of diversity of where these disparities exist. More by age, most established smokers begin during their youth, actually except for African Americans are one of the groups that start smoking initiation more towards early adulthood and less in adolescence. That's a very interesting paradox there. But as you age, you're less likely to attempt to quit smoking. So those 65 years and older are less likely to attempt. I mentioned the rural populations. Those with mental health illness are twice as likely to smoke as the general population. And then, of course, amongst our veterans, active duty personnel and veterans smoke at much higher rates than the general population as well. So I think Tia did touch on in terms of what is the cause of some of these disparities. In my earlier slide alluded to some of that too, with looking at biological factors and then looking at some of the health behaviors as it relates to cancer. But from a tobacco perspective, we can also look at this through a social determinants health lens. And again, just to center everyone in terms of what those social determinants of health this is the World Health Organization's definition. And I'll read them verbatim. It's the circumstances in which people grow, live, work, and age, and the systems put in place to deal with those with illness. It's the conditions in which people live and die, and how in turn they're shaped by political, social, and economic forces, which are characterized by unequal distribution of power, income, goods, and services, which results in unequal access to healthcare, schools, and education. And the conditions in work and leisure settings, homes, community, towns, and cities. And essentially, basically, it's that where we live and where we work and where we play and socialize and congregate, that all of those things are not equally distributed across all racial ethnic groups and definitely not across all of the subpopulation groups that we mentioned there. And so greater resources exist in different communities and people have different access to that. So Tia mentioned the advertising that takes place in more low income and more urban communities from a tobacco perspective, where there's greater norms for smoking in some of those communities, greater advertising, they're preying on those communities. And so, of course, with those type of social determinants, you're going to have different smoking rates than you would have in populations that don't have those similar exposures. So in addition to the social determinants of health, and these are my last two slides, we have the influence of the tobacco industry. Their marketing, advertising, and promotional strategies have been selectively directed at low-income populations, racial ethnic minorities, young adults, LGBTQ populations, as well as the homeless populations, that several cigarette companies have target these communities in specific ways with the LGBTQ population, with distributing free cigarettes at pride parades, with homeless populations, you know, giving out blankets that have advertising for smoking to those groups. So these are some forces that are difficult to fight in terms of the influence of the tobacco industry, and of course it's intentional. And then also the lack of comprehensive policies are also determinants of these disparities that we see. There's inconsistent adoption and enforcement of tobacco policies and support for smoking cessation across the country, so that a lot of the geographic disparities, for example, that we see in the Southwest are due somewhat to these types of policies, where there are fewer comprehensive smoke-free laws in the South and the Midwest. They have lower tobacco taxes, as well as limited tobacco control funding. And we know that policies around tobacco and smoking cessation do work, and are, some of our great advancements in helping to see that decline in tobacco rates that we've seen across the country, but that is not equally distributed across the United States and have contributed to some of those disparities. I think those are my slides, and we'll move on to the next person.
Thank you, Lorna. Thank you, Dr. McNeil. I hope that was very helpful for all to really see a nice comprehensive look at that. I don't want to take up any airtime, so I'm just punting right to Dr. Reitzel to unmute, and you have control of your presentation as well. Thank you, Dr. Reitzel. Take us forward.
Thank you. My name is Lorraine Reitzel, and I had a little difficulty forwarding the slides, but now I think I have it. I am affiliated with the University of Houston Health Research Institute in the Department of Psychological Health and Learning Disparities. And this afternoon, I have the pleasure of speaking with you about tobacco use disparities among one of the groups that Lorna just highlighted, individuals with behavioral health disorders in Texas. And just for definitional purposes, when I say behavioral health disorders, I mean individuals that are diagnosed with a mental health disorder or a non-nicotine substance use disorder. So why is it important to focus on tobacco control in Texas in general? The American Lung Association every year assigns grades to each state with regard to how well they're doing in the dissemination and implementation of evidence-based policies and practices that we know are effective in reducing tobacco use. And so these grades are on a scale from A to F, A being excellent and F failing. So how do you think Texas is doing with regard to tobacco control? It turns out we're not doing very well. You can see in each of these areas of empirically supported tobacco control, we got a grade of F. This means that there is a lot of work that we need to do in the state of Texas in order to eliminate tobacco use disparities and tobacco use in general. However, the good news here, that's a little hidden in all of these F's, is that we do know how to address tobacco use. We just have to get a little bit better at doing it. It's been mentioned previously by Dr. McNeil that smoking and other forms of tobacco use are associated with cancer, particularly lung cancer. It's responsible for 90% of all lung cancer cases, but it's also causally associated with risks for 16 different types of cancers and 30% of all cancer deaths, let alone various cardiovascular and other medical conditions and diseases. Lorna mentioned that the adult smoking rate in Texas, as you can see, is a little bit better than the national tobacco use rate. However, it's not time for us to rest yet, because you can see on this slide that the economic cost that we incur in this state every year as a result of tobacco use is extremely high. Moreover, tobacco use is not only the leading cause of death and disability in the United States overall, it remains the leading cause of death and disability in the state of Texas, accounting for at least 28,000 deaths per year. So now, why focus on behavioral health groups? As Lorna mentioned, tobacco use rates are twice as high, particularly smoking, predominantly is twice as high among individuals with behavioral health care diagnoses relative to the general population. In the graph at the top, you see the red line indicates the past month's everyday smoking rate among individuals with serious mental illness versus individuals with the blue line which are individuals that do not have serious mental illness. And you see that real disparity there in smoking rates. The bottom figure shows the general population smoking rate relative to individuals with various mental health diagnoses. But what I want to also draw your attention to here is it's not necessarily just diagnosable mental health conditions, but also serious psychological distress. These individuals also experience higher tobacco use rates relative to the general population. And so you may say, well, sure, it's elevated, but how many people does this really affect? Well, it affects a lot of people. You look here on figure 1, and you can see that there are 44.7 million adults were diagnosed with a mental illness, and an additional 19 million adults had a substance use disorder. This is a huge proportion of the population, about at least 20% of the population. And these individuals are responsible for 44% of all of the cigarettes sold in the United States. So they're not only using tobacco at higher rates, but they're very highly addicted users. As a result, and not surprisingly, given the fact that smoking and tobacco use is associated with cancer, morbidity, and mortality, these individuals suffer disproportionately from smoking-related disabilities and deaths. They account, in fact, for half of all premature deaths every year as a result of smoking. And it's important to note that individuals with mental illness on average die about 25 years earlier than those without mental health diagnoses, and smoking is the leading risk factor associated with that premature mortality. Moreover, individuals who are receiving, who are in recovery from non-nicotine substance use, half of those individuals will die from their tobacco use that remained untreated despite that they were treated for their non-nicotine substance use. Why is it that behavioral health clients tend to smoke at high rates? As Lorna mentioned, they're often directly targeted by the tobacco industry. There are also mood-altering effects of nicotine that's in tobacco products that is appealing to some individuals with mental health diagnoses. But it's also the case that individuals with behavioral health needs are more likely to be lower socioeconomic status, they're more likely to live in stressful conditions, lack access to care, and help to quit. And why should tobacco use be addressed in behavioral healthcare settings? Well, I think because that's where we can easily find individuals with behavioral healthcare disorders. There are a lot of myths that exist within these behavioral health centers that sometimes impede the treatment of tobacco use in those settings. And I'm here to correct some of those myths for you today. One is that I want to let everyone know that quitting smoking does not necessarily jeopardize mental health recovery. There are, in fact, significant decreases in anxiety, depression, and stress that are associated with quitting smoking relative to maintaining smoking when you have a mental health disorder. In addition, individuals who quit smoking are more likely to experience increased quality of life and greater positive affects relative to those who continue to smoke. And these effects from quitting smoking have been shown to be equivalent to the effects of antidepressants in depressive and anxiety disorders. So quitting smoking can have a very important impact on one's mental health. It can also improve the efficacy of psychotropic medications that are being used to treat the primary psychological disorder, and it reduces risk for the recurrence of psychological symptoms and psychological disorders in the future. I also want to clarify that quitting smoking does not increase risk for suicide. In fact, compared to non-smokers, current smokers are at a greater risk of suicide, thinking about suicide, planning suicide, attempting suicide, and dying as a result of suicide. Quitting smoking does not compromise recovery or abstinence from alcohol or other non-nicotine substances. In fact, quitting smoking is associated with a 25% increase in the likelihood of long-term abstinence from non-nicotine substance use. And individuals who quit smoking are more likely to report abstinence at the follow-up at the end of their non-nicotine use substance care. And it's also important to note that often multiple substance use goes hand in hand. And so tobacco use can actually trigger relapse for individuals who abuse alcohol and other substances as well. There are lots of really good reasons to stop smoking for individuals with behavioral health disorders. And of course, again, the most important one is that 50% of the individuals receiving substance abuse care are going to die from their tobacco-related illness. But there's hope, because if you quit, over time, your body can recover from a lot of the negative effects that tobacco use has. So if it's effective, if we know how to treat individuals with who are using tobacco in behavioral health settings, and we know that it can be effective, what are some of the barriers to doing so? In behavioral healthcare settings, there tends to not be consistently enforced policies that disallow tobacco use on grounds. Practitioners who provide care for individuals with behavioral health disorders often aren't appropriately trained to treat tobacco dependence. And they may have a misconception that among their clientele that there's not motivation to quit smoking. They also may experience elevated tobacco use rates themselves, the treatment providers, which may impact their ability or their potential perceived effectiveness in being able to treat tobacco use among other individuals. It's possible that some may believe that tobacco is actually less harmful than other non-nicotine substances of abuse. And in fact, that allowing individuals to continue to smoke is associated with improved compliance with care. That's a false belief, as is the belief that the implementation of tobacco-free policies on behavioral health grounds would affect census numbers or would affect the number of individuals coming for care at those centers. And then finally, even among centers who are trying to implement evidence-based tobacco control programs, there's often a partial or inconsistent implementation, which really reduces the possibility to address tobacco use in a comprehensive manner. And I'll tell you that tobacco users in these settings do really want to quit just as much as individuals who are not seen in these settings or who do not have behavioral health disorders. So how are we doing with regard to tobacco control in behavioral health settings in Texas and nationally speaking? Here I present data that was published by the Centers for Disease Control and Prevention in May of 2018 that shows both national data as compared to Texas data with regard to things that we know are together form a comprehensive and evidence-based way of treating tobacco use among individuals in mental health treatment facilities, which is at the top, and in substance abuse treatment facilities, which is at the bottom. If you compare the national rates relative to the Texas rates, we see that we're doing pretty well in some areas. In particular, I'll point out that we do better than the national average in offering non-nicotine cessation medications within our mental health treatment facilities. However, we're not doing so good with that particular indicator among substance abuse treatment facilities. Nevertheless, we're kind of in stride nationally. But when you look at these numbers, we want to see these numbers in Texas be a lot closer to 100%, and we want to see each of these empirically supported interventions all be close to 100%, because then we'll know we should really be having an effect on tobacco use disparities among these groups. So what do we need to do in order to do that? Well, we need to start implementing these things in these settings. We need to make quitting tobacco a part of an overall approach to wellness among individuals that we see with behavioral healthcare diagnoses. We need to begin to ask patients at every visit if they use tobacco and advise that they quit. Offer them options for quitting, medications directly, try to reduce the barriers to receiving these evidence-based treatments. And if you can't do that, provide them with the quit line number so that they can reach out and get care, or refer them directly to the quit line so that the quit line can contact them to get care. We need to ensure that we monitor and adjust mental health medications among individuals with behavioral health disorders who are quitting tobacco, because when you drop down on your tobacco, it increases the effectiveness of psychotropic medications and can cause side effects if that's not being monitored closely. We also need to ensure in these settings that we stop practices that encourage tobacco use and include cessation treatment as a part of the mental health treatment and the substance use treatment offered at every facility. One example of how we do this is our program, which is called Taking Texas Tobacco Free, which is supported by the Cancer Prevention and Research Institute of Texas. Our mission is to partner with healthcare organizations to build capacity for system-wide and sustainable initiatives that will reduce tobacco use and secondhand smoke exposure among employees, consumers, and visitors. This entails the provision of many of those things that I showed you on the CDC slide, including a tobacco-free workplace policy development and implementation, basic tobacco education for employees, the provision of evidence-based tobacco use cessation training, services, and products, as well as community engagement and outreach that's designed specifically in order to create an overall context so that individuals with behavioral health disorders are being asked about tobacco use, not only within the settings where they receive their behavioral health care, but also in other primary settings within their community where they can receive the same message from others. It's that context that really helps to facilitate tobacco use cessation among this group. Since 2013, the Cancer Prevention and Research Institute of Texas has supported us in order to implement our program in 22 local mental health authorities across the state of Texas that serve 145 counties across the state. Currently, we're expanding the program to substance use centers as well. I want to give a plug out for those of you who might work in these centers, as well as for individuals that are just interested in learning more. This is our website, www.takingtexastobacco-free. We have multiple resources at our website as indicated here, including a step-by-step program implementation guide if you are interested in implementing this program within your behavioral health facility. Our work has been recognized and promoted by multiple national agencies, including the Centers for Disease Control and Prevention. And I'll just indicate on this slide that we hope that our program is part of the reason that Texas is doing fairly well with regard to offering nicotine replacement therapies within mental health clinics relative to the remainder of the United States. This is a quote from one of our participating representatives from one of our participating clinics, Spindletop Center. And she says, when we started this initiative, it was amazing how wrong we were, because many of us in this field for a long time always assumed that our clients didn't want to stop smoking because they couldn't. Or if they did, their symptoms would get worse. We never even thought to ask them. But once we realized our clients were open to quitting, we really just asked them, and they didn't want to continue smoking. And once we became an instrument to help them, a lot of the clients were really quite successful in quitting. And we've heard this again and again and again from our clients. They really do want to quit, and the good news is that we know how to help them. Thank you.
Thank you, Dr. Reitzel. That was a great deeper dive into specifically what's going on in Texas and behavioral health disorders and tobacco use. Thank you for that segue. Right now we have Dr. Bridger, who is the director of the San Antonio Metro Health Department, and the Metro Health District, changing the name, but she was a part and instrumental in the San Antonio experience for raising the age. And this is also the closing speaker for our Disparities Webinar, and Claudia Rodas is up last to talk about how you can get engaged in the Tobacco 21 effort in Texas. So Dr. Bridger, I'll let you take it away.
Thank you very much. So I think we've covered a lot of some of my background data, so to try to make up some time, I'm going to go through that really quickly. Because the focus is on Tobacco 21, I do want to point out that nearly 2,100 young people under the age of 21 become daily cigarette smokers, and that the reason we care about that is we better understand now that when you expose a developing brain, which the brain is still developing until the age of 26, when you expose a developing brain to nicotine, it changes the structure of the brain, which makes it more addicted to not just nicotine, but other substances as well. So we know that 95% of adult smokers began smoking before they turned 21, and that only 2% of tobacco sold in the United States is purchased by 18, 19, and 20-year-olds. But unfortunately, that 2% supplies 90% of the tobacco products to younger people. So Tobacco 21 is one of my favorite public health solutions to some of the smoking and tobacco use problems we deal with, because it can delay the use of first tobacco and reduce the risk of becoming a regular smoker. It can help keep tobacco out of schools. One of the things that we know is that 18-year-olds are still in high school. And so when the smoking age is 18, they can supply tobacco products to kids still in high school. But if you raise that age to 21, there are many fewer high school kids who are socializing with 21-year-olds. So that breaks that supply chain. Also, it makes it more consistent with the alcohol laws and prevents younger teens from passing themselves off as being 18. So Tobacco 21 is not a new concept. It's been around since about 2014 in a lot of the cities throughout the U.S. We just updated this slide yesterday. Every time I give this talk, we update the slide, and every time we update the slide, there's more and more cities and states that are covered by this. But right now, it's 360 cities and counties in the United States, and 30% of Americans are covered. And you can see from this slide, the states that are completely blued out have Tobacco 21 for the entire state. States that have just their names in red are ones that have, like Texas, just a city or two that have implemented it. So one of the concerns that we heard a lot when we started talking about implementing Tobacco 21 in just a city in Texas was that teenagers would just go across the street into other cities or into the county to purchase their tobacco. And fortunately, we know from the earliest adopter of Tobacco 21, which is Needham, Massachusetts, that when they implemented Tobacco 21 in their city, they saw a steeper decline in their youth tobacco use than the rest of the surrounding cities, even though in many places show this slide to folks who say, oh, it's not going to work unless it's everywhere. It's better if it's everywhere, but it is still an effective intervention, even if you can only do it at the city level. So before we implemented Tobacco 21, we did a survey, and we found that much like another survey that had been done by the American Cancer Society here in Texas and national surveys, that about 3/4 of the population agrees that raising the legal sale age for tobacco to 21 is the right thing to do. So, you know, surveys are great, especially if you can show that your local people agree with the other surveys. So we did that in order to help our elected officials understand what their constituents wanted. We passed Tobacco 21 in January, so almost a year ago, but then we had a period of time where we could educate tobacco retailers in the community, so it didn't officially go into effect until October 1st. And we had a lot of great media coverage when it did go into effect, and we were surprised at how positive a lot of that media coverage was. So I do want to point out that one of the best practices for Tobacco 21 is that you only include regulations specific to the sale of tobacco rather than to the possession, use, or purchase, or PUP laws. And so we in San Antonio eventually came around to that best practice. But what it ends up doing is it makes a difference between if you're under 18 and you purchase tobacco. Texas state law still has PUP consequences. And so in San Antonio, if you're under 18, you can be cited for possession, use, and purchase. If you're 18, 19, or 20, you will not be cited for possession, use, and purchase. The only citations go to the sale of tobacco products to under 21. The enforcement here in San Antonio is done by the health department. Our sanitarians are already in a lot of these establishments doing food inspections, and so it was logical that we would do these inspections as well. When we started educating the community about this, there were about 1,100 tobacco retailers in the city. We reached out to them twice. We created a toolkit to help them understand why we were doing this and help them communicate this to their folks. We also talked to other communities about would they be willing to pass Tobacco 21, and so far we have one other city in Bexar County that has also raised the legal sale age to Tobacco 21. Right before the ordinance went into effect, one of the local news organizations did their own poll, and not surprisingly found that 78% of the people who responded to their poll thought that it was a good idea to ban the sale of tobacco products to people under 21. So that was a nice shout out. And then as part of their coverage, they also interviewed a number of tobacco retailers who were extremely supportive of this ordinance. And, you know, we did have a small vocal minority who spoke against it, but the majority of tobacco retailers, as long as this was consistently applied across the board, were supportive of it. So we do offer technical assistance for anybody who's interested. We're doing that very gently around the statewide effort to raise the age across the state of Texas to 21. So we're kind of on pause with that, but we are here if, heaven forbid, we aren't successful raising the legal age across the state. We'll be here to help cities out if that's something they're interested in doing.
Thank you, Dr. Bridger. I hope everyone's been able to follow the continuum of the underlying things of tobacco use in the state of Texas, the disparities that it's related to and sometimes causes or has an effect, what we can do about it through policy, through interventions, through services. But ultimately, San Antonio's experience is one that was the first for the state. And Campaign for Tobacco-Free Kids, Representative will come next, Claudia Rose, to tell us how you can be a part of the coalition actions you can take, what your employer or organization can do, what you as an individual and citizen of Texas can do. But I will let Claudia close us out. If you do have questions, please type it in the chat box, and we'll be ready to take questions in the last few minutes of the hour. But Claudia, we will forward your slides for you, and you can take over at this point. Claudia?
Hi, everybody. I'm sorry I lost my little button here on how to unmute myself. Well, I do want to say before I end here and people might start jumping off, I do want to say thank you to the previous 4 presenters. We've been planning under the Texas T21 Coalition this type of webinar for a few months now, and so I was so glad to hear all the information that was presented here and being able to tie in together that when we look at this particular issue, we're looking at just for this legislative session at Tobacco 21. I think we need to not forget that all of this may be in terms of messaging and looked at as a youth prevention policy, that there's a larger picture here, right? Especially for here in Texas, when we look at tobacco control policies in the state of Texas completely. And so I love that all the information that was shared today, you know, definitely ties into this policy when we look at it from a bigger picture. So before everyone jumps off, I know I personally want to thank all of you who presented today, and thank you so much for your time and your dedication and your hard work in terms of presenting this to our group today. So I won't have a lot of time today to talk particularly around Texas T21, but I am going to share with you some information and resources and so forth, some websites that you will be able to go to and find out more information. And this coalition came together about 2 years ago. There was a legislative attempt last legislative session. This will be the second legislative attempt coming up next year in 2019. Since then, we have been able to develop more of a comprehensive campaign around this issue. And so we do have some resources that are available on the website, texas21.org. That's www.texas21.org. There you will find fact sheets that you can download, that you can use within your organizations and your constituencies. We have a supporter form that you can either print and mail, email to me directly, and or do an online submission. We also have a list there of all the various coalition members that have signed on. In a minute, I'll show you the various organizations that have lent their logo, whether it's in a supporting form or at least allowing themselves to be used as an educational resource. So there definitely is room for both, for those who are able to do advocacy and those who just want to serve an educational role to still lend your organization's name. And so you'll be able to see some of the other partners here in the state. We're at least over 50 organizations that have signed on. We also have some social media links. So the Facebook and Twitter accounts, you can visit those and link through those through our website, and or look and search for us. And so that's where we're continuing to share information about where we are with this campaign and sharing other resources that are available. Here are a couple of slides on all the various partners who are lending over the last year, have signed on, like I said, in some form in terms of helping to advocate for this issue or lend themselves as an educational resource. So I am proud to be representing the Campaign for Tobacco-Free Kids here in Texas and joining all these organizations. We're coming in strong on this policy for statewide. Thank you, Dr. Bridger, for your presentation on San Antonio, because that really is the springboard for this particular issue here in Texas as we fight to get this statewide. So I'm going to end with that. I don't know if any questions have come up in the chat section. I'm going to turn it over to you, Jennifer.
Yes, we just had one come in, and this is for Dr. Bridger. Has there been any response from retailers in San Antonio about money lost in the few months since October since it went into effect?
No, not yet. We expect that they are monitoring that, and we very much want to monitor that as well, because national research says that it's about 4% of their revenue comes from sales of tobacco to 18, 19, and 20-year-olds. And some of again, that vocal minority, I think, overestimated the impact on their bottom line. So we're going to be monitoring that, and we'll definitely be sharing that.
Thank you, Dr. Bridger. One question about slides, the infamous question about slides. Yes, we will share our slides, but to be efficient, we want to share the link to the webinar and the slides at the same time, so they'll be sent probably Monday or Tuesday, so this link can actually process and be downloaded on Friday, so it'll follow up in an email through your RSVP on Monday or Tuesday with slides and the link, because we know this is valuable information. You want to share it with a colleague, you can have both to do that. So thank you for that question. Any other questions? I appreciate Claudia cutting out a few of her slides to save time. Thank you, Claudia, for doing that. Since we're waiting for questions to come in, I will go back 2 more and just show that we have our Facebook, Twitter, and website here for you. Several of your organizations may not be on the list, and if you would like to be on the list, there's our form that you can go online and fill out, or you can download it, and then you can join the list of those who want to either educate on the issue using these facts that you've learned today, or if you can advocate, there is a section for the advocates to sign up. Any other questions? Yes. What are the prospects for passage this year? Claudia, I'm actually going to turn that over to you to talk about the likelihood in the last 30 seconds of passage for the 2019 legislative session.
Well, I'm being optimistic today, so I'm going to say yes, we will pass it next year. So no, I mean, I think we base off of the type of support we we received last year on this particular policy. We got bipartisan support. The bill moved out of House Public Health Committee and was on the House calendar. And so we're, you know, in terms of some of the conversations that are happening with legislators right now, it seems very positive. This is a youth prevention policy, and so that is really helping in terms of knowing that this is a policy particularly for the youth, and we are seeing some really great support from leadership and on both sides of the aisle on this issue. So we're very optimistic.
Yes, thank you for that question. It is 4 o'clock, so we're going to wrap up and stop this recording. Thank you so much for joining. Thank you to our presenters, Tia Lorenze, Lorna McNeil, Lorraine Reitzel, Colleen Bridger, Claudia Rodas. We wish you best of luck in your endeavors and keep joined into this effort on tobacco21.org, our Facebook and Twitter page. Have a great afternoon. Thank you, everyone.